Good afternoon, everyone. This is Robert Hess III with Hess 3 Consulting, and today we're here to discuss incorporating evidence-based practice into planning as part of our strategic prevention framework series that we are running with the University of Arkansas at Little Rock. So for those of you that maybe have not met me before and or participated in one of these presentations, I have about 16 years of experience in health and human services. A large part of that has focused around prevention, as well as working within the formal healthcare system with insurance companies, as well as with large providers in substance abuse prevention or behavioral health, and helping folks kind of figure out approaches either from an environmental strategies perspective and or from a direct clinical practice perspective, how we can best help people recover and hopefully prevent substance use in the beginning. So for today, what we're talking about is incorporating evidence-based practices into planning. And so we have a couple learning objectives, of course, to increase knowledge about how to identify and locate evidence-based practices, how to assess whether an intervention qualifies as an evidence-based practice, and of course to increase technical capacity to utilize evidence-based practices when facilitating strategic planning. So before we dive too deep, I wanted to kind of contextualize our conversation. So for most folks on the call or on the webinar, hopefully everyone is familiar, has seen the strategic prevention framework before. On the left, we can see that this is an evidence-based process model that's been founded by SAMHSA, really focused on development, promoting development, reducing risk-taking, building assets and resilience, and preventing problem behaviors. The first step of this process, and contextualizing this is really important as we continue through, because we're going to kind of bounce around a little bit and see how this really starts in step one, which is the assessment process. In step two, we're talking about capacity building, which is a large part of what today's conversation is going to focus on, but it's really capacity building to prepare us for planning. And so these first three steps are going to be a large part of our conversation today, but of course, they're intertwined, and we really want to start from the very beginning. And then later sessions in the series will focus more concretely on planning, implementation, evaluation, of course, sustainability and cultural competence. So the strategic prevention framework is kind of the hub of the series that I'm working and will be presenting over the next couple of weeks and months with the University of Arkansas at Little Rock. So we're going to start with step one and briefly, again, just kind of contextualize. So when we're conducting a needs assessment, we're looking at assessing the current substance abuse epidemiology or substance use epidemiology in our particular community. And so a lot of our coalitions are regional, they're county specific, they're city specific, they're region specific, or at least they're state specific for those that may be working statewide. And so when we're looking at substance abuse epidemiology, we're looking at trends. So what are the significant areas that everyone is doing, or where are we seeing those big, large swaths of substance use? And then we're also looking at outliers, and that might be within a subpopulation, or when we kind of stratify or pull apart our data a little bit, looking at special populations by either race, gender, ethnicity, sexual orientation, whatever that might look like, veteran status, looking at where we may see certain subgroups that are either using and or abusing a particular substance or substances in general, more so than their peers or than the general population. So trends, of course, focusing on kind of the general population, and outliers looking at those kind of specific stratified subgroups. Of course, we're going to use asset mapping, looking at existing programs for prevention and treatment. So again, we're looking at the need, we're identifying the resources that exist in a particular area, so national, state initiatives, whatever funding priorities may exist. We're seeing nationally and in a lot of states across the country a really strong emphasis on the opioid epidemic, and with that is coming a lot of funding, and so looking at those funding priorities. And then, of course, social determinants of health, And then looking at the need versus the resources, so kind of a gap analysis, we identify the greatest areas of need, and we identify what our coalition priorities are going to be. So this is where we're going to focus a lot of our attention today, because in order to know what evidence-based practices we want to look at and where we want to focus our efforts for the remainder of this conversation, we have to know what our priorities are. So if wherever you may be in your coalition process, that can really drive kind of how you're going to approach or how you're going to utilize today's conversation. So I know for a lot of coalitions and that I've worked with across the country, they do a needs assessment every 3 to 5 years-ish. It's very rare, at least I've seen it be very rare. I've not seen it very commonly where you see coalitions doing needs assessments every year. And so for some groups, it might have been a while since you've conducted your needs assessment. And there may be some opportunity to either do a check-in, do a mini assessment, do a reassessment, pull some literature, some stats from the state to understand what the current issues are and really kind of have a conversation. And we'll talk about this as we get into strategy and planning, but have a conversation with your coalition members or with your agency around what your priorities are. What may have been priorities 5 years ago may no longer be priorities or issues. And again, as we've seen, there's been a big national shift away from some of the substances that were really hot topics a couple of years ago, such as marijuana or even alcohol. And really, there's such a strong focus on opioids. So we're actually going to use that as our example as we go through today's conversation. So as most of you guys have gone through, when your coalition does its needs assessment, you're going to look at all the data and you're going to identify what priorities may exist. And so just for the sake of conversation and in our training today, we're going to use the problem of opioid misuse. We want to further unpack this because as we fast forward, I promised you we were going to jump around a little. So as we fast forward, we know that we're going to have to target some of the specific underlying causes or root causes. And so we really want to have a thorough understanding of contributing environmental factors. So this is our mock root cause analysis. Why is opioid misuse a problem? Well, because we know doctors may be overprescribing, so maybe they're giving too many pills at the point of at a clinic visit. There's a lack of monitoring systems and or pill shopping, so I can go to one doctor in Hot Springs today and I can go to another doctor in Little Rock tomorrow, and they're not in the same system. There's no way for them to know that I went from one doctor to the other, so I get to double up on my pills. The patient may become addicted post-medical necessities. So what I mean by that is you go in for surgery, it's a legitimate surgery, you're prescribed Dilaudid or some type of opioid for pain management after your surgery, but you become chemically addicted to it. You didn't anticipate it. It wasn't something that you wanted to happen, but because you were in such pain, because of a legitimate medical need, you became chemically addicted and or socially addicted to those opioids. Of course, easy access. So going back to a physician potentially overprescribing, but also I just had back surgery this past year, and I know that I was prescribed a lot of pills, and I did not use them all. And so because I hadn't used them all, they were in my house, which made it easy, or potentially would have made it easy for someone else, a roommate or a child or a spouse or a cousin or a friend that came over to visit, to open my medicine cabinet, find and have easy access to those medications. So that easy access is a really significant component. And then we all know that poverty is really an underlying environmental factor that for why we see a lot of maladaptive behavior. So of course, people may use substances to cope with poverty, but people may also sell substances or try to gain access to them as a means to mitigate poverty. So whether that be through drug dealing and or, again, through using medications to cope with the stress of poverty. So we're going to take our first chat break, and I'm going to ask those of you sitting around your computers with a keyboard handy to participate and engage with us. So what other key components are contributing to the opioid epidemic in your community? So there's no wrong answer, but I'm going to look to some of our participants to chime in. What are you guys seeing in your local areas in Arkansas that are specific to the opioid epidemic, or if you want to speak more broadly to substance misuse? What are those underlying causes? Go ahead and chat in the chat box for me. Or if you're feeling exceptionally bold, you can unmute your microphone and verbally speak. I know that this is a problem in Arkansas, so I'm definitely going to look for some participation. Teresa, good and faithful Teresa, you always participate, which is why I remember your name. So yeah, lots of good stuff. So the problem was ignored for so long. We saw it coming 9 years ago. Yeah, that's true. A lot of people, especially if you've been in prevention world for a while, we've been talking about this for a while. Being so close to Missouri, yeah, that's actually really a fantastic point, Liana. Forgive me if I mispronounced your name, but being able to cross state lines, being able to go get medications over there. I'm originally from Arizona, and of course we're so close to Mexico. It's not uncommon to hear folks talking about going down to Mexico to get medications because you don't need a prescription for all medications down there, and so they can easily go get them and bring them back. People with poor dental work, yeah, and dentists overprescribing pain medicine. A lot of times we don't consider dentists within the formal medical community. I mean, they're in the formal medical community, but they're not often connected to like a hospital or something like that. And so, yeah, we do sometimes see that. Veterans Affairs, yeah, being exempted, that's definitely or can definitely be an issue. Parents, education, and of course, the prescription drug monitoring program is a really significant part, and we'll talk about that as an example throughout that. Not enough permanent drop boxes for disposal, yes. So Darla, that's a great example, of course, of addressing that easy access that we talked about. Awesome, thank you guys. This is the type of engagement I'm hoping we'll be able to sustain. You guys made me very happy, so thank you for participating. So specific to opioids, we're going to carry that through as our example and keep bringing it up and talking it through. But what we also want to focus on is the step of capacity building prior to planning. So again, you have to, I recognize this might have been a couple years ago for some folks. So you've considered or you've already completed your needs assessment and it identifies that there's an issue. For sake of conversation, we're going to say we've identified that the opioid misuse is an issue in our community. So capacity building ensures that we as a coalition or as an organization, if we're a nonprofit or whatever the structure, if we're a part of a hospital, whatever that may be, capacity building ensures that we have the tools and resources that we need to do our job. So this is my very generic definition, but it includes knowledge, skills, abilities, equipment, technical tools, etc. So before we move to that third phase of strategic planning, we really want to spend some time on this capacity building component, which is what we're going to be talking about today. So of course, step one is to review that needs assessment. And, annually, you want to go through capacity building before you do annual strategic planning. And I'm making the assumption that that all the coalitions and groups and folks are going through an annual strategic planning process. If you're going through it every 2 years, that's fine. If you're doing it every 6 months, that's also fine. But before you move into strategic planning, you really want to take some time to review the needs, maybe do a mini assessment, maybe update the needs assessment, whatever that might be, so you know what the current baseline lay of the land is. And then we want to look at, what are other people doing that is excelling or that is working in other areas? Because of course, we're constantly learning and evolving. And this is what we're going to talk about today. And then we want to leverage that research to inform our strategy development. So the next couple of slides, we're going to bounce around a little bit as we talk about how do we do this. And there's a couple of components. We're going to kind of break into two segments. The first one is looking at, kind of the world of evidence-based practices that exist today. And I don't think that there's going to be any remarkable, eye-opening aha moments for folks. At least maybe there are, learning some new resources, but I think those of us that have been in this world for some time kind of know where some of these resources exist. But then we're going to talk about, how do we really monitor our own intervention. So the work that we're doing and we're putting into our strategic plan, how do we monitor that? And then again, I feel like this presentation is a little out of order because then we're going to talk about, how do we do these steps in preparation for planning. So please go with me on this journey as we kind of weave through some of these topics. Because by the end of our time together today, I hope it all ties together and makes sense. So when we're talking about reviewing evidence-based practices, there's some really low-hanging fruit out there, which again, I hope most folks are familiar with. The first step is SAMHSA's website. So SAMHSA for many years has been maintaining and aggregating its substance abuse prevention evidence-based practices library. And what this is, and there's the link is right there, and there's actually a handout. I don't know if Derek has sent it quite yet, but we're going to be emailing you a handout that also has a bunch of other resources for your libraries where you can go and search the evidence-based practices that we already know work. And so on SAMHSA's website, obviously you can go to this link and find out what are the exemplary substance abuse prevention programs that are in place all over the country that have been proven or have an evidence basis to them. This is a fantastic first step. And as we'll talk about later on as we dive into like adapting and customizing and making like homegrown solutions or grassroots solutions, you really want to have a firm understanding, of what these programs are, what's being successful, what evidence is or what evidence supports as far as interventions go, because that's going to give you the scope of the universe. Another list of libraries, and again, there's a handout that will be sent to you if you haven't already sent it, or if it hasn't already been sent, but it will be sent out that has these lists, these databases, or these libraries, I should say, in addition to a bunch of others, or a handful of others that are specific to behavioral health conditions or social conditions, as well as substance abuse conditions. If you've not spent some time kind of perusing these websites and getting familiar with the various programs, I definitely recommend that you do. But I'm saying that with the caveat that none of these programs may be appropriate for the work that you're wanting to do, and that's okay. We believe firmly in the whole structure and component of, or focus of the strategic prevention framework is that these are community-based interventions, which means that your community in your particular town or city or county drives this process. And kind of the whole point of today's conversation, if I had to summarize it in a sentence or two, is to say that incorporating evidence-based practice into planning really just means that you have some really strong subject matter experts as part of your coalition that know the scope of the universe, right? That have their finger on the pulse of what is happening in substance abuse prevention programs around the country, so that as you custom tailor solutions to your community and as you develop solutions for your community, you'll do it within the context of knowing what works and knowing what doesn't work or what hasn't been proven effective yet. And so, as I was saying, so you really want to take some time to review these websites. There's really specific programs out there that work for, specific subpopulations. One of my mentors and friends of mine developed the Keeping It Real program, which is an evidence-based practice focusing on substance abuse prevention in middle schools. I want to say they focus on seventh graders very specifically. Traditionally, the program is designed, or the evidence supports that it's effective for Hispanic seventh graders in the Southwest, which means the evidence only points to, Hispanic kids that live in Arizona, New Mexico, and California. And if you're not in one of those states, then their evidence doesn't support their program in your state. And so, again, learning what they do that makes their program effective. But then we're going to talk later about adapting programs and being able to apply that within your context, because maybe you're focusing on a specific demographic. So again, maybe that's children of veterans or Native Americans, or if I'm not mistaken, is it Arkansas that has a large population of the Malese community? I know that there's a special island community that has a strong concentration. Yeah, from the Marshall Islands. Yes, thank you. Marshallese, thank you. I was just working on the implementation of the organized care model in Arkansas over the last couple of months. And so I was doing a whole bunch of population analysis, but it's been a little while, so forgive me for the lapse in memory. But so, there may be specific interventions that might work with tribal communities or other migrant populations, but there might not be one specifically targeted to the Marshallese population. So there may be some adaptation that needs to happen, forgive me. So I don't know if you guys have any additional resource libraries that you're aware of that are not included on this list or in addition to the SAMHSA one. But I wanted to pause and do some collaborative sharing. So if there's anyone on the phone or on the webinar that is aware of any other libraries, or where do you guys go to get your research or data centered around evidence-based practices, or even staying up to date on substance abuse prevention, and even if it's statistics, that's fine. But if you've got a good link or library that you can think of off the top of your head, will you go ahead and throw it in the chat box for us so we can do some resource sharing? And I'll let you guys do that as I continue talking, but I wanted to make sure that we had that opportunity. So again, throw a link in the chat box if you are aware of a really good resource library or data warehouse that is specific to substance abuse prevention that may be of benefit to one of your colleagues. So we're going through this list. We're searching SAMHSA's website, and we are looking at these different programs. Now, it's probably safe to say if it's on SAMHSA's website or on the CDC's website or something, that there is likely some strong rationale or justification for it being there. But we also want to be prudent and make sure that we are giving our best judgment in analyzing these programs. And I bring this up because oftentimes what happens, especially if you are well connected and talking with other coalitions or connected to national work groups, or maybe you're attending a conference. I personally attend a lot of conferences. And you will hear a session, a plenary, or a workshop on a program that's being done in Kentucky or in Wyoming, and a group, a coalition, is presenting their findings. While what they may have accomplished may be successful, it's also important that we have the skills and ability to kind of judge and critique and or weigh what they're saying with evidence, with statistics. And so I am by no means attempting to take us all through a statistics course. For those of you guys that have studied and gone to school, some of this may be second nature. This is not my super big area of expertise, but there's a couple of key things that we really want to think about. And so when reviewing evidence basis of other programs, we really want to check the rigor of the evidence. And what we mean by rigor is the strength of that evidence. So, if someone says, oh, we've had great outcomes, well, what does that mean? Or, we're seeing observationally, or we're seeing, a drastic reduction in, opioid overdoses. But what is that evidence based on? Is it, your personal observation? Is there actual data being collected or aggregated from emergency departments? Are you looking at vital records information with cause of death and seeing a reduction there? It's really important to drill into the how do you know that? How do you know that it's true, so that we are not replicating things that we think work or that we feel work, but the whole component or the point of looking at evidence-based practice, of course, is that there's evidence to support it, and that evidence be scientifically valid. And so, of course, there's such thing as weak evidence and strong evidence, which is judged by power, which is a statistical term, power. And of course, we want to look at, when we're looking at a program or when we're looking at a research study, whether it be from, I'm really surprised. So if you guys didn't see anyone type in a resource, but the most common resource and probably my favorite resource that I use, and it's just because I am a little simple is Google Scholar. I just typed that into the chat box for you. But Google Scholar is, where they've taken all the open access data and research that exists out there, and they have compiled it. And you should be able to access most of it for free. Every once in a while, you'll come across an article that they'll charge you for. But if you're connected to a university, either a student or faculty or staff member, a lot of times you can get that. You can gain access because those institutions, research institutions, typically purchase group licenses to it. So if you're looking for a study and you find one that's really good and you don't have access to it, call your hopefully child that may be in college, or a friend of yours, or a researcher, or someone at UALR, and they might be able to help you pull it, or a library, a local, like actual library, brick and mortar library. I think those still exist these days. And a librarian can help you find it. But so we're looking at, when looking through empirical research studies, which is the segue there in my head, we really want to look at the study design if it's appropriate, looking at the sample size, how many participants were in the study, looking at the significance that is found in those results. So again, I'm trying not to be too statistics heavy, but looking at the p-value, you really want to find a p-value that is less than 0.05. And what that means is that there's less than a 5% chance that we're wrong. So the p-value is the risk of being wrong. And so if it was a 0.10 p-value, then that means there's a less than 10% chance that we're wrong. But in hard statistics science, we're really only looking, we don't want there to be more than a 5% chance that we're wrong. So we want that p-value to be less than 5% or less than 0.05. And of course, the most critical component, or at least, a core component of any scientific rigorous study is the acknowledgement that correlation does not equal causation. So just because two things happen together, just because people attended your workshop and your training, and then people report that they felt more hydrated after your workshop, that doesn't mean that your workshop hydrated them. It doesn't mean that participating in your workshop hydrated them. Those are two different things that are not necessarily related. And there's lots of really funny examples that I probably should have prepared a couple. But there's lots of examples of where two things are correlated but absolutely not related. It's a spurious correlation. Because what we're looking for in evidence-based research is trying to get towards causation. We want to know that our environmental strategies or our intervention that we are implementing as part of our strategic prevention framework process and our public health interventions, that we are causing prevention. We don't just want it to happen by chance. We want to cause people to stop using opioids or to stop opioid misuse. So we really want to focus on that causal relationship, not just the correlation, which does take some, really focused paying attention and cueing in when we're reading evidence-based practice. And we're going to talk about this again later when we talk about adapting programs. So here is a quiz. So I went on Yelp, which is one of my favorite applications in the world. I'm a big Yelper, largely because I travel quite a bit and I'm always looking for good food. So I figured that I could use a food analogy. So looking at these two reviews on Yelp, I've never been to actually either of these restaurants, and if either of you have, please let me know which one is actually better. But looking at these two reviews on Yelp, which restaurant would you go to? It's lunchtime, I'm hungry, you're hungry. Where would you guys go? And I'm going to look for you to type it in the chat box, which one you would go to. All right, so I'm seeing a couple of differences here. Okay, so lots of folks are saying pantry, lots of folks are saying district fair, or a couple of folks are saying district fair. And so the big question here is why? And again, it is related to what we're talking about, I promise. And so statistically speaking, what is the significance here? Yeah, so Michael and Tiffany hit it on the head here. So while District Fair has a 5-star review, it only has 6 reviewers. And so it's a good chance that those 6 people probably are owners and or work there. So they probably have a bunch of bias. But 6 is not a relevant sample size, or it's not a statistically significant sample size. So the pantry, while it has 4.5 stars, it has a much larger group of people that have gone there, and so you can trust that those 231 people, is the result or their rating is more valid than just those 6 people. And this happens a lot in our studies, and that's the whole point of this tie-in here, is in our needs assessments and or in our outcomes evaluation, which we're about to talk about and dive into. We might have 6 people show up to a training and all 6 people rate that training as it has changed their life, right? And but 6 is not a statistically significant number. And so, or it's not a statistically significant sample size, excuse me. And so when we are doing quantitative research studies, we really want to pay attention to this. And when we're reporting the evidence basis of our programs, we really want to make sure that we don't have to all have master's degrees in biostatistics or PhDs and statistical analysis and stuff, but just taking pause to think through, what if there is a statistically significant finding in what we're reporting, because we're talking about evidence-based practices. Evidence-based practices require that there is legitimate evidence to support our findings, and legitimate evidence requires statistics. And so, I know that this isn't everyone's forte. It's not my forte. I've spent a lot of time doing number crunching, and I have arrived at a point in my life where I don't ever want to use a calculator again. And more importantly, I don't ever want to use Stata or SPSS or SAS or any of the other statistical analysis softwares again. And so there's definitely, an advocacy in a room here for us to recruit the expertise. And I know that this is going to be on one of our slides in a little minute. Recruit folks who really have this expertise to help guide us as we are designing or identifying or proving the program effectiveness of the work that we're doing. So thank you for playing along with me. And if one of you has a legitimate recommendation over one of these restaurants, please private message me, because next time I come to Arkansas and Little Rock, I will check it out, because I do like to eat a lot. Okay, so Michael asked a question. Speaking of evidence basis, I have a question. I saw something a month and a half ago, maybe 2 months ago, with a list of words not to be used out of the White House. One comment, one of those words was evidence-based. What's up with that? So there's a lot of layers to that conversation, Michael. So the first is that those words, from what I understand, and I do not work for the White House and the current administration or any office or department or the CDC. My understanding is that the guidance was specific to the budget document and not more global. It definitely, was brought and applied more broadly. However, it's what we're referencing today is specific to our efforts in Arkansas, and so evidence-based practice or using evidence to reinforce findings is math. I mean, this is the core of science, and I personally, really wouldn't worry about that going away as the norm or as accepted practice anytime soon. I know that the science community has responded quite strongly to the fear of and some of the outcomes or interpretations of what that memo was about. But in our work, so in our work, and I can look to Lorraine and other folks in Arkansas to help chime in, but it's my understanding that we would still anticipate and expect to utilize and implement evidence-based practices within our efforts. Oh, so yeah. So the other thing that's also has happened recently, and Darla's writing a comment about this currently, is the National Registry of Evidence-Based Prevention Programs. So what also happened recently, a little bit separate and apart from the banning of the word evidence basis in the budget process, is the vendor that the federal government has used to manage the National Registry of Evidence-Based Prevention Practices. Their contract was also terminated within the last, I even want to say within the last month, if I'm not mistaken. Um, so vendor contracts change all the time. I know that there was some fear that that meant that the National Registry of Evidence-Based Prevention Programs was going away. It's not my understanding that the website will be shut down or turned off or go away. It is my understanding that a different person or different company will be running that website now. Part of the reason why I submitted a handout, though, is also so you can have direct access to these links. So again, it's a Word document that will be sent out if it hasn't already been sent out. And that will give you a number of opportunities, a number of different resources to go and draw from as far as identifying those evidence-based practices. So yeah, we'll keep on doing the good work. And, you know, of course, government gets to do whatever government does. It's beyond my control. So all I understand or all I focus on is, you know, keep preventing substance use because that's what we're here for. And we're just going to keep doing what we know to do. I hope that that was an appropriate response for folks, and I apologize if I offended anyone with any of. I hope none of that was taken politically because it wasn't meant to be political. So when we're looking at our looking for evidence within our own programs. And so we're kind of what we're talking about right now is not looking at somebody else's program that may have been a part of the registry, that maybe we found it online or someone else has gone through a really thorough evaluation. But when we're looking at the actual uh, evidence of our own program, so our intervention that we are doing in hot springs or wherever that might be, to really create change in our communities. So we're looking at two different things. Process evaluation. So did we do what we said we were going to do? If we contractually committed to distribute, 1,000 brochures about opioid misuse, did we distribute 1,000 brochures or did we distribute 100 brochures? That's a process evaluation. The next component, and this is a little bit more abstract, is the outcome evaluation. So did it have the effect that we intended it to have? So did those 1,000 brochures on opioid misuse that we distributed, did it actually reduce opioid misuse? And that can sometimes be, it requires a different type of data. And sometimes that data is not even our own. Maybe we're looking again at vital record data that's being collected by the local hospital or being reported to the state for our specific county. And so what I offer here at the bottom is should not be anything new for folks that have been participating in some of these webinars. Actually put on the side of here on the right, there's a little caveat that I talk about this a little bit more in detail in telling your story through data, which is a presentation we did last April. There's a recording that's available on YouTube, as well as I'll make sure, Derek, that I send the PowerPoint back out to you just in case you're interested in some of this, how do we report data and how do we use this template? So again, you can go back and watch the recording of the webinar that we did last year and or just flip through the PDFs of the PowerPoint. I'll make that accessible for you. But one thing that I always advocate for is using this specific template. And the reason I do that is it merges project management and managing the process evaluation. Again, did we distribute 1,000 brochures like we said we were going to, with the outcome evaluation? So you're going to have your goal. Your goal is most likely going to be to reduce opioid misuse in our county. The activities: print 1,000 brochures, distribute those 1,000 brochures. The inputs: it's obviously the graphic design time, the printing costs, and then whatever the manual labor or people, whether that be volunteers or paid staff, we're going to distribute those brochures. The person responsible, whomever you identify in the coalition, or the multiple people that you identify in the coalition, your due date, of course. So if we're mid-year, and we've only distributed 100 brochures, we know our process evaluation is not doing so hot in our current progress, because by the middle of the year, we should have distributed half of that, right? So there's an opportunity to monitor progress. The outcomes data, again, is going to be different, and it may be outside of your control, but maybe you look every month at vital records. So every month you go on the state's vital records website and you pull down the number of deaths attributed to opioids within your county. And then you can track it month over month in your outcomes column. And so you can see, the correlation between the number of brochures that you distribute and the number of opioid deaths that take place. Now, here's the truth. Going back to correlation is not causation. So you may see that you distribute brochures around opioid deaths, or around opioid misuse, maybe the deaths increase, and that would tell you that your brochures are not driving the outcome that you wanted, but maybe they do decrease, and you want to really you've identified that there's a correlation between the number of brochures that you distribute and the decrease in opioid or deaths attributed to opioid misuse. So you've identified correlation. And again, correlation is not causation. And if you were looking to publish, empirical research around this and around your activities, you would really need to do a more robust data analysis that would look at all of the potential variables to make sure, or to help define or strengthen the relationship between the number of brochures that you distribute and the reduction in deaths attributed to opioid misuse. I'm trying to keep that very simple because again, this is not a statistics course, but as we're looking for true evidence-based practice, we really want to make sure that if we're trying to get our programs to be considered evidence-based, or even as we're doing our own annual evaluations or routine evaluations of our progress, considering can we absolutely say that it was our intervention that made this change, or could there have been other things happening that maybe also contributed? And again, we can talk that through offline, or I can refer you to some really fantastic statistics books that you can read in your free time. Again, not my area of expertise, or at least not my passion. It's not my personal passion. But so looking again at this strong research design, so there's a couple of reasons why we want to cover this. So again, as you are looking at evidence-based practices, making sure that you have the tools that you need to be able to critically analyze them and make sure, did this program that we're considering implementing in Arkansas, did it do its homework, and is it up to snuff? Is it actually evidence-based? And then as you are implementing your own homegrown solutions or adapting a program, and you're evaluating your own program, making sure that that evaluation is considering all of the components that are necessary to actually be considered an evidence-based program. So the research design is an art and a science. Basic steps include, defining your hypothesis. I'm sure all of us can reflect back to elementary school or middle school as we learned the scientific method, and it always started with a hypothesis. I struggle with this sometimes because I'm like, I don't have a hypothesis, I just have an answer. Like, I already know what the answer is. Like, there is a substance abuse disparity in my town. I know people are dying of opioid misuse. I don't know, that's not a hypothesis, it's a problem, it's defined. And so sometimes the hypothesis is obvious. But then you look at your study design. So this is important because, again, this goes back to critically analyzing an evidence-based practice that you're looking to implement, but also evaluating your own and making sure that you are constructing your evaluation appropriately to really highlight your successes. So there's lots of study designs. There are dozens and dozens and dozens of study designs. And then there's like subtypes and all kinds of things. Again, that's a whole course. It's a whole degree. It's multiple degrees. You can get a PhD in this. But to keep it very simple and things that apply to the work that we do, there's a cross-sectional study, which is known as a snapshot in time, which is very similar to our annual surveys or to a pre and post test. If you're doing a training and you're going to do a pre-test to collect the baseline, what do you currently know about opioid misuse, and then the post-test, immediately after the training is over, and you can judge change in knowledge. Those are both snapshots in time. What do you know right now about this issue? So like an annual household survey, an annual health assessment, anytime you're logging in a Survey Monkey and creating a tool that folks will fill out online, all of that's considered a snapshot in time study. A longitudinal study is looking over an extended period of time. So when you're looking over multiple years, the impact of how many times, this is where you see children that were abused as a child are more likely to physically abuse as a child, are more likely to abuse opioids as an adult. And so you're looking, at there's some type of incident or exposure that happened at one point in time, and you can either follow them over the next 10 to 20 years to see whatever happens, which is called a prospective study, or you can retrospectively look back. So you look at people that have maybe gone into treatment or self-identified opioid misusers or addicts, whatever term you want to use, and you can interview them and say, right now you're 30 years old, tell me about your childhood. Did your parents smoke in the house? Were you ever physically abused? Those types of things, and you can identify correlations that way. So cross-sectional, like the snapshot study, is the most common thing that we're going to be using, or at least the most common thing that I see. And again, that's, fill out the survey, tell us about your life, and then we'll run some analytics on it and some statistics. The sample size calculation, we talked about this earlier with our Yelp example. So for statistical significance, the general rule of thumb is you want to have at least 30 participants. So again, for us, hopefully very pragmatically, if we're doing a community survey or if we host a training and only 10 people show up, it's definitely worthwhile to run the numbers on that training, but know that they're not statistically significant. So what might be best is to do another training and maybe 3 or 4 trainings and kind of lump all the participants together until you can get a statistically significant sample size. So that your findings are going to have a little bit more rigor to them. They're going to have a little bit more strength when you report them. And then your sampling methodology. So you're just going to randomly find people on the street and ask them questions. Telephone surveys, which is how some of the census, like midterm census, are done, or how some health surveys are done, etc. Or what's called a convenience sampling, which really means, like I'm going to set up shop at the grocery store, and everyone that walks in the grocery store, I'm going to ask these questions to. Or there's tons of methods, but random sampling is really the gold star. And then however else you may recruit people, recognize that may introduce bias into your study. And again, you'll see at the bottom here, recruit an expert, find an expert. It's really important that you have someone that has a PhD or has studied statistics, or someone that can help you, really kind of set this up correctly. Brian, I see a question. Does the evidence-based practices library provide a printable version of the PowerPoint? Brian, do you mean this particular PowerPoint that we're going through today? If you can be more specific, I can definitely give you an answer. I will make sure that this PowerPoint is made available, so Derek will email it out. I meant to send it out to you, Derek, before we started, forgive me, but I have the PDF available for you guys. Okay, so then the next couple steps are things that we're probably very accustomed to. So we're collecting baseline data, we do a literature review, we look at state data, or again, if you're doing a training, maybe that's that pre-survey, what do you know about opioid misuse today? And then you're going to collect your study data, which is different. So this would be either that post-test, which means, this is what we know about opioid misuse after they took our workshop or training, and then you'd compare baseline data to study data, and you'd be able to see the difference. So we learned a whole lot. We saw an increase in knowledge. That's a outcome, a desired outcome, so that's great. Or if you're doing one of those cross-sectional studies we talked about, one of those snapshot in times, you're sitting in front of that grocery store and you're stopping people and asking them questions, that can be your study data as well. And maybe you're asking them, have you ever do you have prescription drugs in your home that you are no longer taking? Do you know how to properly dispose of them? Like those types of things may be included in your study data. If you're being more formal and you're connected to a hospital or the health department, you may even do a medical record review, and that means of the 100 people that died in the last 30 days in this particular county, how many of them passed away or had opioids in their system at the time of death, regardless if it was the cause of death. And you can, gain access to those medical records and do some data collection that way. Of course, you're going to analyze that data, spend some time reviewing it. Again, this is where you need that statistician who's an expert, and reporting findings. And that can be, the graphs, charts, however you want to do that, a narrative, but making sure that that information is presentable for folks. I'm going to move a little bit more quickly because I just realized I'm running out of time, so forgive me, guys. And so building an evidence base this is one of SAMHSA's required steps. And so you build an evidence base around your program based off of time and longevity. So the longer that the program is there, the more data you're going to be able to have on it. And so you're able to see that the program is able to repeatedly produce results. Using a broad data set to control for confounders and allow embedded cohort studies. And so when we talked earlier around the correlation versus causation, this is where you want to really spend some time. Again, you're going to need a really good researcher or statistician to help you design this. And again, look at a university, or there's definitely technical assistance groups, there's consulting groups, there's folks who do this for a living. But looking at all the data that could potentially be contributing and making sure you're collecting data on it so that you can run statistics. And subgroup, or what are called embedded cohort studies, is looking at those subgroups. And so looking at the demographics that you're collecting, if you wanted to maybe look at opioid misuse for your entire county, but then you also wanted to focus specifically on the Marshallese population. You're going to want to make sure that you collect, what is your ethnicity or country of origin, or are you Marshallese, yes or no? So you'll be able to stratify or segregate or pull out the data just for that particular group. Peer review, so have folks that really know data and stats and programs take a look at it and say, hey, how do you feel about this? Does it look like our evidence is strong enough? Is there enough rigor to it? Do the outcomes make sense? Having peer review is really helpful. So that is something that your colleagues on this webinar can help you with. Folks at UALR can probably be good resources or help you identify and connect you to folks that could also be really good resources. Doing numerous studies. So if you were to design a school-based program for opioid misuse, and doing numerous studies means that you're going to study it multiple times in different ways. So, if it's high school, look at, the impact of your program on adolescent males. And then, the following year, you can do the impact of your program on adolescent females. And then you can do another study on the role of teachers in school-based opioid misuse programs. You're creating a body of evidence or a basis of evidence on your program by conducting multiple studies. And then, as we described before, longitudinal data, so tracking those people over time. We did a high school-based opioid misuse program back in 1990, and the people that participated in that program, it's now 28 years old or later. We should all feel old by that number. But 28 years later, they are still people that participated in our intervention 28 years ago are less likely to misuse opioids than people that did not participate in the intervention. So looking at those longitudinal studies, again, for many of us, we've been in this business for a long time and in substance abuse prevention for a long time. And so just anticipate, that the impact of your work will go on. And so being able to measure that and use data to construct that will reinforce the evidence basis of your program. So I promise we're going to be jumping around a little bit, and we are almost to the end. So now fast forward with me or jump to the strategic planning process. And so one way that we can incorporate evidence into the strategic planning process, if you recall from the beginning of this webinar, we talked about reviewing existing literature. So we know, we're looking at those evidence-based practice libraries. We're looking at empirical research studies that have been done around the country on specific programs. And again, we're going to focus on opioid misuse. So we're looking at all of the best practices around opioid misuse. So we then have to somehow communicate this and bring our entire coalition or agency or executive leadership up to speed to make sure that everyone knows what we now know around effective evidence-based programs for opioid misuse. This may include the data from your own program. So we know that last year, the thing that really drove the most change or the most impact, was the fact that we did a follow-up call after every training, after every workshop that we held, to make sure to answer folks' questions, whatever your data says. So you have to host this level setting meeting, or at least it's something I advocate and I tell folks to do all the time. So of course, agree upon an objective. If you can bring in a third-party facilitator, I highly recommend it. When you're doing strategic planning, review history, mission, history, mission, vision, and values of your coalition and your organization. Of course, make sure that there's an understanding of regulatory and contractual requirements. Of course, go back and review your needs assessment, specifically your gap analysis, your readiness assessment, and SWOT, but then always review evidence-based practices and empirical literature. So bring this, all this effort and work that you've been doing around knowing what evidence-based practices exist out there into your strategic planning process. And you can do that in a number of ways: a PowerPoint, a brief, an annotated bibliography, a conversation. You can bring in the experts if they are local or if you have access to them, making sure that, as you're trying to solve or plan for whatever your next steps are going to be in the upcoming year, that everyone has an understanding of what the problem is, what has already been done in the past by your coalition, what's happening in the universe around opioid misuse. So what is Louisiana doing? What is Georgia doing? What is New Hampshire doing around opioid misuse? And how can that help inform our strategies locally in our city or town or county within Arkansas? So that before you start devising your specific strategies for the year, everyone's on the same page. And it might make sense, depending on the amount of time that you have, the amount of work that you're doing, or where you're at in the life cycle of your agency. Spend time on this. It is really important, and it will dramatically change the way that your strategic planning process goes. So again, this should be pretty easy or second nature. So based off of those needs assessment findings, so again, the needs assessment findings for our example was that there's a problem with opioid misuse. So identify the target issues. So opioid misuse will be our target issue. Conduct that literature review. So again, revisit that handout. This is a summary slide of what I just said. Compile that annotated bibliography or PowerPoint slides or samples of curriculum, whatever you want to do. Shortlist those programs or evidence-based practices that best align with your community, your target population, your needs, your assessment findings, and include promising practices and innovation. So I've been beating pretty hard the statistically significant evidence basis of some of these programs, but it's not harmful or bad to incorporate promising practices. Maybe they haven't gone through a full evaluation yet, or there's not multiple literature research studies published on a particular program, but it's promising. It's showing really good results. We've gone through and analyzed, their outcomes evaluation, even though it's not been published in a journal. And we've met with them. We've had conversations about what works, what doesn't work. It's a promising practice. Feel free to include that in your strategic planning process. It's important because that's, they will be evidence-based next year or in 2 years or in 3 years. So it gets you ahead of the curve. I know that I'm over my time, so forgive me. But adapting evidence-based practices, no evidence-based intervention will be perfect to fit your community. So the important thing is look at the evidence. What is the causal factor. What are the components that make the intervention work? If you're doing a workshop, the fact that you ordered cheese pizza is probably not what drove the change in opioid misuse, or the fact that it was done at a community center versus a church, or is facilitated by a female instead of a male. There are probably some programs where those things matter, especially if you're talking about like sexual health or pregnancy or things like that. Having a female instructor teaching a female probably does matter, but it doesn't necessarily matter if you're talking about opioid misuse. So identify and really look at those studies, identify what made those programs effective, and do not change that part of it. I think that's self-explanatory, but it is amazing, how people either in the process, they dive in too deep and then they forget about those causal contributing factors, and they end up changing it, and then the program that they implement is no longer effective, or they didn't pay attention to them in the first place, or they focused on the wrong thing. What I call majoring in the minors. So make sure you pay attention to those things and do not change them. And then again, I was going to ask you guys to provide some adaptations, but we're over our time, so I'm going to go ahead and skip this little activity, which is the end of our time together. So if you have questions, please go ahead and type them in the chat box, and I'll make sure to answer them. I'm going to go ahead and copy this link for you again into the chat box. So in order to receive credit for participating in today's webinar, you must complete this training evaluation, and please do so within the next 48 hours so I can get it over to UALR so they can process all the participants. But please take a moment and type up any questions you may have. I'm available to hang around and answer those. Also, my email address and my cell phone number are listed on this slide. You'll get a copy of this slide deck via PDF, as well as that handout that we talked about. And I will include the previous training that I referenced in today's session. I'll include a PDF of that as well, and the link to the YouTube video of that recording. So you guys will hopefully have lots of resources. But if you don't have any questions, we are officially adjourned. Please complete that evaluation so that we can record your participation for today. Otherwise, I'll hang out a couple minutes, and you guys have a fantastic rest of your afternoon.